We're super excited to be here today with Dr. Dustyn Williams. Now, Dr. Williams attended undergrad at Yale and medical school at Tulane University School of Medicine. He is a board certified physician in internal medicine, and he's a hospitalist at the Baton Rouge General, where he's the clerkship director for internal medicine and the associate program director for the internal medicine residency program. He's also the co-founder and lead educator of Online MedEd, which is an online learning platform for medical students, which we're going to learn a lot more about today. So thank you so much for being here with us today, Dr. Williams.
My pleasure. Thanks for having me.
Absolutely. You gave such a killer presentation in last year's summit that we want to have you again and talk about similar topics, but slightly different. So the first question
I got last time. Hopefully I can live up to it.
It's great. Okay, so first question here is medical students in the United States are offered approximately 19 to 20 hours of nutrition education during their entire 4-year stint learning medicine. And what that shows is that most physicians just aren't trained adequately on the power of lifestyle change over prescription medication. So if somebody comes to you, given that you were trained in this classical system, somebody comes to you, they present with an A1C over 6.5%, or they have elevated fasting blood glucose. Can you explain to us what's the sort of typical treatment algorithm?
Diet and lifestyle changes. So there's like this, even if you will go to the ADA website, you actually look at like, how should I treat someone with diabetes? Always in the right-hand side is diet and lifestyle changes. And the reality of that is that nutritional education that medical students get is like, what happens when you have a vitamin deficiency or you have hypervitaminosis, something else, malabsorption syndrome? It's not really what is nutrition and how do you use it to treat somebody. So when I say diet and lifestyle changes, really what I mean is you should eat less and exercise more. Calories out, calories in, right? And so like that makes sense, like net balance. If you lose weight, then the A1C will go down and you're less likely to become diabetic. So it's like, whoa, hey, that's like a warning sign, 6.5, hey, looks like you got diabetes. Time to start diet next step, diet and lifestyle changes, and come back and see me in 3 months.
That's it. It's as simple as that.
Right. Well, of course, it's wrong. Not that at all, right? Like the problem with that is that it's not right because I don't actually know what diet and lifestyle changes really means. Most of the diet and lifestyle education that medical students get is that when they realize, oh shit, I'm gaining weight in medical school, they then go try one of the fad diets or try to eat less and exercise more and attempt to get the weight off. So really their diet and lifestyle education comes from their own attempts or failures at trying whatever happens to be popular in the market. So what I'm saying is that most physicians probably know as much about diet and lifestyle education as whatever you see in magazines and TV, as much as the patients do. And that's not true of everybody. Some people do get involved in nutrition, but for the most part, it's like diet and lifestyle changes. Your A1C is not high enough for me to pay attention to yet. Why don't you go talk to my nurse educator and see what she has to say? Because I bet that she knows what she's talking about. I don't actually know what she's talking about, or if she knows what she's talking about, but at least there's someone else I can offload you to go talk to someone else, not me, because I don't want you to know that I don't know.
Right. Okay. So, all right. So let's say, somebody gets this recommendation. They end up doing some Googling and they come across Mastering Diabetes and they start actually making some smart diet and lifestyle changes. They might need to see their medications reduced. So
that would be great. Yes.
So let's spend our time together today discussing these common diabetes medications so that people can understand two things. Number one, what does each medication do in your body? And number two, what side effects are worth paying attention to? So we're going to focus on a long list here. Let's start at the top with insulin. There's bolus and basal insulin. What do you have to say about those medications?
All right. So like insulins are sort of what were reserved for type 1 diabetics, right? Type 1s must have insulin. They can't use any of the medications very well. They don't make insulin themselves, so they need to replace that insulin with injections. For type 2 diabetics, insulin is sort of become like the thing of last resort like after you've tried 2 medications and an injectable that might cause pancreatic cancer, then you can start insulin, and you start one of those insulins. So insulins in general are like severe type 2 diabetics and type 1s must have them. In terms of safety, the insulins are the most dangerous, right? Insulins are the hormone that your pancreas normally secretes to tell your cells to take up the glucose that's in the bloodstream, therefore reducing the blood glucose. And the ones that are the worst offenders, or the best offenders, depending on what you look at it, the ones that drop the sugar the most are the bolus insulins. What you're supposed to do is say, I've got some carbs in front of me. I'm going to give myself this rapid-acting insulin, rapid-acting because it's absorbed quickly from the injection site, and gets peaks in your blood quickly, and then clears your system quickly, because what they're trying to do is simulate what a normal pancreas would do. I eat food, blood sugar goes up, pancreas is like, yo, you know, only with the bolus insulin, you give it to yourself a little bit ahead of that meal because your pancreas isn't going to do it, and you're hoping you match the right amount of insulin for the carbs you're about to eat. You miss when you inject too much insulin and you don't eat enough carbs, that's going to tank the blood sugar. So the highest risk of hypoglycemia comes with the bolus insulins, which is why when we educate somebody on bolus insulin, the simple phrase that I picked up in Nowhere, Louisiana was, you shoot, you eat. You do not eat, you do not shoot. Right? And that clicks with people, right? Because the worst cases of hypoglycemia have been people who are out at dinner, right, with like the boss, right? They know dinner's coming. They go to the bathroom, giving themselves the injection, and food takes an extra 20 minutes to show up, and the insulin is acting right away. And then they don't have any food to eat, and there goes your blood sugar. If you give basal and you're not giving excess, it takes a long time to get in your system, takes a long time to peak, takes a long time to clear, but it also doesn't do a very good job. So if the only insulin you're on is basal, and you know what your dose is supposed to be, and you don't take too much, it's hard to cause dangerous levels of hypoglycemia. It is okay to give the basal insulin for like a day or two, right? And then while you're checking the blood sugar every 4 hours to make sure it doesn't go low, right? So obviously it can go low, but it's much safer than the bolus. The problem with that though is the pancreas always secrete basal insulin. And then as you eat something, it goes up with the blood sugar rise to compensate. That basal insulin doesn't do anything for the food you're about to eat. So bolus insulin injection tanks your sugar. That's the whole point. It's supposed to correct whatever you're eating. Basal insulin is still insulin, so you're injecting yourself a thing that causes the blood sugar to go down, but it's not nearly as dangerous as the bolus.
All right, so that's excellent. That's a great overview of both bolus and basal insulin, which, like you said, are the most likely to cause hypoglycemia as you become more insulin sensitive while changing your diet. The next class of medications that's very commonly prescribed are sulfonylureas. Can you go into a little bit of detail about what they do and what types of side effects people should pay attention to?
Sure. They're basically giving yourself insulin. Right? Only instead of giving exogenous insulin with the syringe, you take a pill, and that forces a pancreas that can make insulin to make more. In type 1s doesn't work because you don't have a pancreas, those cells are gone. Right? But in type 2, insulin resistance develops as over time, the weight goes up, the calories go up, and the pancreas tries to keep up, but it can't. And so sulfonylureas tell the pancreas, work harder, bro. Right? And they hit the pancreas hard, and the pancreas has that insulin to secrete, so it does. So it is an insulin secretagogue, which means it tells the pancreas to secrete insulin, which basically means taking that pill is very similar to taking insulin and all the side effects that insulin has, like hypoglycemia being the most prominent and dangerous. And then the most common is weight gain, which worsens the insulin insensitivity. So the things that I have to watch out for sulfonylureas are kidney disease, right? So if you're a physician, you're going to prescribe someone something, you say, well, the ADA basically has said any medication class is good to go. Just pick one. Sulfonylureas are cheap. They're effective because they do lower the blood sugar, but they're a little dangerous in people who have kidney failure, chronic kidney disease, or those who develop acute kidney injury, because the medication itself and the insulin it secretes are cleared by the kidney. So if you have bad kidneys, it's really hard or harder to clear that medication. And if you have an acute kidney injury, you have no idea that this happens, right? You don't feel anything, just your number goes up. And what ends up happening is toxic levels of insulin develop, and that's when you get hypoglycemic events. Sulfonylurea is good meds, cheap, but high risk of hypoglycemia because they effectively secrete insulin.
Okay, now down the road, are people likely to burn out their pancreas, for lack of a more technological way to say it, as a result of using a medication that's promoting their pancreas to secrete more insulin over time?
I think it's, well, not medication necessarily causes this, but it's going to be if you have insulin resistance and all you've done is push out more insulin, you're going to still be resistant to the insulin, right? So yeah, it doesn't affect the pathology of the disease. You need to reverse the insulin insensitivity by losing weight and eating better, because all you're going to do is actually promote weight gain, worsening the insulin resistance, and eventually it's not going to work anymore. So yes, burnout, but that's not the medication itself that causes it. It's just it's going to be the side effects of that medication could cause worsening of the diabetes itself. Not the diabetes because your blood sugar is controlled, but you gain weight anyway, and that worsens insulin resistance.
Okay, that makes perfect sense. So next class of medication here are called meglitinides. These are commonly prescribed as well. Talk to us about these guys.
Same thing as sulfonylureas. I don't really understand how. I'm sure that they are different, right? But these are also insulin secretagogues. They make the pancreas secrete more insulin. They have the same risk. They're not as well studied, right? They're newer, right? But the sulfonylureas are like one of the first medications we ever had. And these new guys, which are really hard to say, are basically the same thing. They make the pancreas work harder. High risk of hypoglycemia, causes weight gain, and eventually they won't work anymore because you burn the pancreas out. So the most important thing I think to take away from that is don't be on both, right? If they both cause hypoglycemia and they both lower the blood sugar, right, you might get prescribed both, right? Because they may not realize that they have the same mechanism of action. And then when you take them both, it's like taking double dose of insulin, and insulin causes hypos, and that's what's going to happen.
Right. Okay. So next class of medication here, GLP-1 receptor agonists. So this is also an injectable medication, but it's not insulin. So an example is Trulicity. What about these medications?
So mixed bag on these guys. We thought that these were going to be like this amazing breakthrough, right? Because they're injectable and people don't like to inject insulin. Often type 2 diabetics see it as some sort of failure, and we just learned that insulin can cause hypoglycemias. And so the ADA said, try one oral medication. If that doesn't work, try a second one. If that doesn't work, add a GLP-1. And it is an injectable. And the GLP-1, some of them can be injected like once a week. And there's very little risk of low blood sugars. And they cause weight loss. Weight loss from the medication itself will reduce the insulin sensitivity. Sounds awesome. And so there was an entire morning at the ADA 2 years ago, the national conference, where it's like, GLP-1s are the bomb. This is the thing. Everyone should do this. And then the afternoon was, well, they cause pancreatic cancer, massive GI upset, and after you stop studying them, the effect isn't seen. The reason is we don't really know how that works. Right? We know they're GLP-1s, but like, what does that do? How does that affect the things? And it's like, well, drop the A1C, good enough. So what ended up happening was people have really bad GI side effects. So what I tell people is, if you're going to use it, type 2s, right, go ahead. And if it works for you and you have no symptoms, awesome, right? Like, good for you. You're going to have weight loss. It is a good medication. It's better than starting insulin because insulin can cause hypos and cause weight gain, and then that worsens the disease. But if you have any, like, and this is what I'm like really aggressive about it, any side effects like upset stomach, tummy hurts, abdominal pain, pancreatitis, don't get off. Just like, because there's a super small risk of pancreatic cancer. I don't want people to hear, take this med, get pancreatic cancer. But there have been a lot of minor pancreatic issues. And the way you're going to notice that is by having pain when you eat. Right? So if you have GI symptoms on these things, either get off them and get on something else, or talk to an endo about, is that thing that I experienced from this drug?
Okay, so how about DPP4 inhibitors?
They are sort of the like the other one, right? There is they're good, but they're not like amazing. They have almost no risk of hypoglycemia. They're weight neutral. Side effects are basically like non-existent, but they cost a lot. Like they're fairly new, so it's sort of like the safe one. And it doesn't really doesn't really control blood sugar that well, but doesn't really have any of the negative consequences. So it's like, oh, let's just pick this one because it's like these two didn't work. Let's get on this one. And usually how I see them being used is a person's already on two and they don't want to do an injectable. So even though we know that this doesn't work by research, the provider will put them on a third, and it'll usually be these, right? But you have to have good insurance, otherwise they're massively expensive.
And a common one of these would be Januvia, Janumit. That's things that people may be familiar with. And
they're popular. I mean, they're all over TV, and they're good because they don't cause that many problems, but they don't do that well either. So it's like if you just need a little bump, like one more A1C reduction. And also, I've also seen them as like let's try 3 orals. We know this doesn't work, but it's sort of like proving it to the type 2 diabetic. Like, hey, man, we're going to give this a go, but diet and lifestyle modifications, and maybe we can get off that third one. But then it's like sort of the third drug.
Okay, so let's talk about the SGLT2 inhibitors, because these are actively marketed on television right now. And common medication names are Invokana, Farxiga, and Jardiance. Can you give us a little description of what they do and what side effects are present?
Sure, and I gotta flag this with a little personal bias, right? Because I'm a hospitalist, so I see the catastrophic consequences of these medications. When I saw the commercial for it, I thought to myself, that sounds like the exact mechanism of how people go into DKA. What they do is they block glucose reabsorption from the kidney, right? So your kidney filters everything, plasma, blood, not red blood cells, but like electrolytes, water, and glucose. And it does that to clear the blood. And then the kidneys are supposed to say, well, I don't want glucose in the urine, because what's going to happen is waters are going to follow it and we're going to lose all the volume. So the kidneys are designed to take back the right amount of blood sugar. Turns out that the kidneys cap, their ability to do that cuts off at about a blood sugar of 180. So if your blood sugar is over 180, what's happening is you're spilling glucose into the urine. And glucose is osmotically active. Water follows it, right? So it causes diuresis, which is why when type 1s present for the first time, they are drinking all the time, eating all the time, peeing all the time, but losing weight. Well, they're drinking all the time and peeing all the time because their blood sugar is too high. Kidney can't keep up with how much blood sugar it's filtered. And that's also how people with type 1 diabetes goes into DKA, right? They get massively dehydrated. So the SGLT2's mechanism is to take the kidney's ability to reabsorb glucose at 180 and reduce it, right? So that's great because the kidney can't reabsorb the glucose. You spill the glucose into the urine. So your blood sugar goes down. The only problem with that is it causes euglycemic DKA. And actually, when I was at that ADA conference, I walked up to the guys who make it, and I asked, well, what should I teach my students and residents about it? And they literally handed me the pamphlet. And they're like, oh, we know you. Because I have reported now 8 cases of euglycemic DKA, right? Because literally the mechanism of action of this drug is the same thing that puts diabetics into DKA. So they do lower the blood sugar. And I've actually gotten a flack from a lot of endocrinologists who said that these are really good medications for the right patients. In particular, since they cause you to lose water, they're diuretics, patients who have heart failure and diabetes might find them beneficial, because in heart failure, you want to take the fluid off. And if they also have diabetes, you want the blood sugar to be low. Problem is, how does the person know they're going into DKA or they're going into a massively dehydrated state? You can't tell. The other problem is weight loss, hypo risk really low, chances of euglycemic DKA extraordinarily low. I just happen to see them because I see hospitalized patients. But if you get dehydrated or get sick, you can end up in catastrophic state. So I personally discourage people from using them unless they also have heart failure. but they are on the market, and there's lots of endocrinologists who say that their diabetics do great with them. It's like the thing that could kill you right now, other than a hypo, they can do. So personally, steer clear.
Okay, so let's not also forget the fact that these SGLT2 inhibitors can cause acute kidney injury. And
right.
More than 50% of cases reported to the FDA, these events of acute kidney injury occur within 1 month of starting the medication itself. Right, so it's a relatively rapid deterioration of kidney function. But just like you're saying, it's such a dangerous proposition that steering clear of the medication in the first place might be a much smarter alternative.
I personally think that's the case, right? You are going to dehydrate. You're going to, like, the kidneys are going to take a hit because you're constantly dehydrated, right? And then it's just like you have so many other things to use those instead. Unless you are the very particular person where you want that diuretic effect, in which case it's worth it to talk to somebody about using it, which by that I mean heart failure.
Okay, great. So let's move into the next class of medication here called isoladinediones, otherwise known as TZDs. Common medications here include Actos, Acto Plus, Met XR, or things like Avandia or Avandamet.
Yes, indeed. These were great drugs, and if you talk to any endocrinologist, they'll tell you they should still use them. But what happened was 1-800-BAD-DRUG got a hold of these, and so now everyone is terrified to use them. I mean, they work so well. They have no risk of hypoglycemia, but what happens is they cause weight gain because they cause fluid retention. Well, if you have heart failure and you hold on to fluid, just the opposite of the diuretic effect, you essentially exacerbate heart failure. So the TZDs are great meds, except they can cause fluid retention. What people remember is the huge lawsuit, TZDs cause heart failure, which is incorrect. TZDs don't cause heart failure. TZDs put people at risk who already have heart failure to go into heart failure exacerbation. That's a lot of words to remember, so people remember TZD heart failure. So if your endocrinologist puts you on one of these medications, just stay on it. It's good. If you have congestive heart failure and someone makes a recommendation for this, say, maybe I should do a different one. But almost no one in primary care will ever prescribe this because what everybody knows is TZDs and heart failure. So because it had the bad rap from the lawsuit with 10 plus years ago, no one's going to use it. But they're actually really, really good at treating diabetes.
Okay, so next class of medications here. I'm probably going to butcher the name. Alpha glucosinase inhibitors.
Sure, actually it's pretty close. Yeah, right, like medications like a carbose, right? So don't use these. These are ancient. No one's going to want to be around you because it causes really bad flatulence and diarrhea, right? They block the absorption of glucose from the gut into the bloodstream, which is fantastic. If you can't, you eat whatever you want, take a bunch of this, and all the glucose doesn't get absorbed. But what it gets delivered to is the bacteria in your colon, and they love it, and they ferment it. And those like Pumbaa and Lion King, you'll be able to clear the savannah after every meal. So they aren't, and also it's terribly uncomfortable, right? You're gonna be farting all the time, be terribly bloated. Like they work, but like not well enough to tolerate the side effects. Right? It's like, but there's no risk of hypoglycemia because it like prevents like the absorption of what you're eating. But like they're not like they're like a way to cheat weight loss and be really uncomfortable. So I wouldn't recommend anybody use it.
So effectively, what it's doing is it's blocking glucose from the carbohydrate that you're eating to actually be absorbed and you're in your small intestine. And as a result of that, that glucose ends up in the toilet. But you also end up with, terrible flatulence and GI disturbances. Is that right?
Yeah, before it hits the toilet, it gets the bacteria in your colon, which love it, and it causes all of the terrible side effects. Yes. Right? So and the goal is to never absorb the glucose in the first place, which actually is a really good like concept, but like the side effects are just embarrassing and actually pretty brutal. Not life-threatening, just really uncomfortable all the time.
Right. I like how you use the word embarrassing because it truly can be. Okay, next class of drugs. This is the sort of the mother class of all drugs because it's the most commonly prescribed diabetes medication. The big one, metformin extended release, otherwise known as glucophage or glucophage extended release. So talk to us about metformin and why it's so widely prescribed in the first place.
So when I was trained, what the recommendation was, you see somebody with diabetes, put them on metformin. If there's a reason not to, don't find something else. But the first medication is metformin. And what you do is you put them on whatever dose you can start them on. Usually it's 500 twice a day. And the goal is to get to 1,000. This is not like a titration. You just get them up to that. Metformin causes diarrhea, but it also stops after your body gets used to it. And the goal is to get to 1,000 twice a day or 1,000 XR once a day. What it does is it sensitizes the system to insulin. Right? So diabetes is all about insulin resistance. And it comes metformin and resensitizes the system. So there's almost no risk. I'm going to say no risk of hypoglycemia because it doesn't add any insulin. And your body is already producing insulin. And so you add the metformin, it makes it work better. So it's old, super effective, very well established, and causes weight loss. And it's actually so popular that it's now a fad to take metformin to live longer. There was a study that showed that people with diabetes who took metformin had less chance of cardiovascular disease than non-diabetics who didn't take metformin. I don't actually know the validity of that study, but it's become very, very, very popular for people just take metformin to be healthier. And in metformin also has a lot of other things that it helps treat some other endocrine diseases. For a diabetic, type 2 only, metformin does a really good job of being safe, tolerable, causes weight loss, reverses the disease by making insulin more sensitive. The only real problem it has is the diarrhea you get when you first start using it. Oh, by the way, terrible lactic acidosis. So that, by the way, happens in people who have kidney disease. Metformin is cleared by the kidney, and so you can't use it, or you shouldn't use it in someone with chronic kidney disease because it'll cause an increase in buildup of lactic acid. There's also question mark heart failure. Question mark because if you have heart failure and you're taking those diuretics like the SGLT2s, you have the risk of inducing a kidney injury. And if you have kidney injury and you're on metformin, it can cause lactic acidosis. So in my mind, everyone gets put on metformin unless they have a reason they can't be put on it. It has none of the bad side effects like hypoglycemia. It has all of the good benefits, insulin sensitization, weight loss, and it doesn't have a dose titration. The only thing is you have to watch out for your kidneys. So it's the best medication we have. It's the oldest and it's the cheapest. So usually what happens is you get to see a diabetic, metformin, and diet and lifestyle.
Okay, so I like the fact that you actually talked about insulin sensitization because you're right. Metformin does sensitize your liver and muscles to the action of insulin. However, if you were to compare how much insulin sensitization occurs as a result of metformin versus how much insulin sensitization occurs as a result of a plant-based whole food diet, we're not even talking the same ballgame here, right? We're talking a completely different sport.
So that's a good point. Yeah, right. Metformin, you can expect a change of 1% on your A1C with any oral medication, right? So metformin does sensitize the system. It's good for you, but the amount of A1C reduction you're going to get is not that powerful. None of these medications are going to be whoa, my A1C dropped 5, except for insulin when your A1C is 12, right? It's supposed to be 7. So metformin, but also I think metformin is one of the safest. So if you have diabetes already, you can be on it. It's the last medication to go because you want that sensitization. If your pancreas is still making insulin, then you want the system to be sensitized so the pancreas has to make less and has less chance of burning out and recovers faster. So if you're going to start one, it's this one. If you're going to remove one, it should be the last one. But the actual change is going to be 1%.
Right. So it makes a difference, but it's a very small difference in comparison to lifestyle change, especially in comparison to the lifestyle change that we promote, whole food, plant-based nutrition that's low in fat. The change in insulin sensitivity that we routinely see here is on the order of, we're not talking about a 15 to 20% change in insulin sensitivity. We're talking about a 200, 300, 400, sometimes as much as 1,000% or tenfold increase in insulin sensitivity as a result of adopting a low-fat, plant-based whole food diet, which, just like you mentioned, no medication, none of the classes that we've talked about can compete with, period, end of story. It's not possible.
Right. That's actually correct. Right. The only one that sensitizes the system is metformin, and the A1C reduction of the other ones often come at some other consequence.
Exactly, 100%. Okay, so let's shift gears here just a little bit, because you're one of the founders of Online Med Ed, which, like I alluded to earlier, it's this online platform that teaches medical students how to study and pass their board exams, but also a lot more. So you started creating videos. You put these videos online, and before you knew it, you had, correct me if I'm wrong, 60% or more of the medical student population in the country watching your videos?
We're up to now about 150,000 logged in users monthly. That's more medical students than there are in the country. So like, obviously it's more than just med students who are using it. When I started it, it was just me in my bedroom because I wanted to teach, and no one would give me the chance because I was a med student. And it turns out I'm actually pretty good at this. The first time I wasn't, though. Like the first iteration, the videos you're not going to find. There's a fire at Google. You can't. They're not even cached anywhere. Like literally, you will not find the first set. But after the second and third iteration, I got better at whiteboard teaching. And what we ended up doing was creating an entire paradigm of learning, right? It's called PACE. Students can study at their own pace: prime, acquire, challenge, and force. Which really means there's a note set, there's a video you watch, some questions you can do, and then flashcards and a book to use to review it. But what we do special is, and what my co-founder Jamie says is my power, is that I can organize and simplify complex topics, so down to just what you need to know and how you need to know it, and put things together so it sticks. And all of that pace is with one unified voice, mine. Now, I don't know everything about medicine. We of course have people who look at our content to make sure that it's done right, and we ask for help in building it. But ultimately, it's the output is through my voice. So the student feels is I get the same information, this highlighted the same way, discussed in the same way, for multiple modalities, which maximizes understanding and retention. Videos are free, right? And so one of the main mission was medical knowledge belongs to no one. So medical education should be accessible to everyone. So all of our video lectures are free, but if you want to do better on the test, you have to pay for the premium content. Otherwise, we wouldn't have a company.
Fair enough. But so we created some videos together.
Yeah.
We created an entire nutrition curriculum here, which talks about how to use nutrition to reverse a lot of the common chronic diseases that most people in the United States are suffering from, such as type 2 diabetes, high cholesterol, hypertension, atherosclerosis, chronic kidney disease, coronary artery disease, right? So that was a very fun opportunity. And, I see into the future taking your genius in creating board videos and starting to move more into the lifestyle space. Because as you know, lifestyle modification is right now, it's a giant black box for doctors. Diet and lifestyle modification. That's what they say, but they don't actually know what it means. But the thing is it's not their fault. So, over the course of time, as Online Med Ed grows and grows and grows and starts to create more lifestyle-oriented videos and curriculum for doctors, there's no doubt in my mind that especially the younger generation of doctors now are going to be very interested in learning that information and using it to as their next level of education.
I think it's actually true. I don't think that medical students don't learn about nutrition because they don't want to, right? They don't learn about it because it's not tested on the board, so maybe they don't want to, right? And someone who's going to be like an ear, nose, throat surgeon probably doesn't care about whether or not their patients are losing weight. But at the same time, there aren't resources available that are easily accessible, that are low cost, and that are good. Right. So the information that most medical students learn is whatever's in magazine and popular culture because they try them themselves. So if what I'm hoping to do, right, is we have the niche right now of people studying for their wards and their boards. We're building into the preclinical years where the basic science is. So basically what we'd have is an ecosystem of students who start off with us, who trust that we're telling them the right thing, right? They do well because of us. And then as they begin to matriculate out of medical school and these things become relevant for them to learn, we remain the source of truth or the source of knowledge. They're accessible through us. So they never have to leave, right? It's these guys have been with me the whole time. They've gotten me through everything and nothing else is out there worthwhile. Oh, look, they have a thing specifically catered for what I want to learn. Great, here it is. right? So that way, one, we build trust, and then two, we have the number of people who are looking for the stuff with also the thing to give them.
Exactly right. Exactly right. Yeah. There's just like you're saying, doctors want this information. There's a whole army of doctors out there that are beginning to realize that the pharmaceutical based education that they receive and the system that they have doesn't actually reverse the underlying cause of chronic disease. Now, for those doctors who are, have been practicing for some period of time, and also for the new generation of doctors that are currently getting trained, learning nutrition is something that I think is becoming a lot more appealing so that they can actually treat their patients and reverse the conditions that their patients are presenting with. So,
I like to believe that for sure. but I will say though, like the current system is see as many patients as possible, right? And so like someone who's in practice right now is incentivized, and actually some people have to, you give their patients as little time as possible to get the documentation done to get to the next guy. So they're hoping that someone else will learn the education, the nutrition stuff, right? And so yes, the doctors want it, but and as more people adopt a better practice, as whatever changes in healthcare administration, I think that it's going to be more relevant for physicians to know. But it's also going to be very challenging for people who will go see their primary care physician who's been practicing for 20 years. It's going to be really hard for that person to then change their current practice to go learn about something and then implement it on their own. Right? So for the people who are coming through and are learning how to create their practice now outside of the HMO thing, and as the old people retire and new people come in, it will be much more important for the new generation to have the access to this stuff, because it does matter. It will become part of their practice, and it will become part of their practice pattern. Doctors don't like to change. So the old guys are probably going to keep doing it the old way, right? But the newer generations are going to be present, and they're going to be learning what they need to learn and going to be putting that into play. So the sooner we can get them better educated, the more likely it is to get established into their practice and become a routine thing versus a black box where they don't know what the hell it is.
100%. And you're at the forefront of that, I think, and we're also trying to be part of that positive change as well. Trying to educate, not only people living with diabetes, but also medical professionals who are treating the people living with diabetes about the power of lifestyle change and especially plant-based nutrition.
Well, come make some more videos.
I'm on it. So thank you for taking the time to be here with us today. I think you're one of the best speakers at talking about the way that medicine works and the sort of lack of effective tools that doctors are providing when they're in medical school. And one of the things that I want people to take away from this interview here is that if you're frustrated with the care that you are receiving from your doctor or from your medical team, before you get frustrated at them, realize that likely it's not their fault. Okay, your doctor is probably very altruistic and wants to help you become a healthier individual. They just don't necessarily have the training that enables them to do so. So that's why, paying attention to things like this and really participating in summits like this and learning from doctors that actually understand how to reverse chronic disease is the first step in the process. So long-winded way of me saying thank you for taking the time to be here with us here.
My pleasure, guys, as always.